So before we get started, when is a good time to build your weapons? Before the war? During the war? Before the war. So you want to build your arsenal during peacetime, right? Is that what we've been doing? How many think we've been doing that sufficiently? So that's why ARTPARK exists. ARTPARK is AI and Robotics Technology Park at the Indian Institute of Science. Before I go into the health side, I wanted to first share our model. So we build innovations and innovators broadly in two areas, Industry 5.0 and population health. And we have been created as a nonprofit by IISc to be a translational and application-oriented entity. And we work at the intersection of three ecosystems. Of course, research and academia, but also government, and most importantly, perhaps startups and corporates. This is our fundamental model. Typically, the incubation model is you see what startups already exist. You ask what innovations are close to making money. If you are a donor, you ask what innovations are close to giving you, societal returns. We often do not ask what will we really need in 5 years' time or 10 years' time so that we really can make economic and social returns, right? That's essentially our model. We do everything as innovation projects or programs. We start at a super early stage, sometimes just starting with the need. And then these innovators and residents go on to become startup founders and such. And for societal impact, a lot of our work goes out as digital public goods. Core to that are industry and government collaborations, and often with international entities too, right? And we are able to do this. This is our quick portfolio. We've built 23 startups in addition to supporting startups in incubation model. We have built 7 award-winning social innovations, mostly in health. That's what I'll mostly focus on. And we also have 2 pioneering India-scale data initiatives. All this is enabled by an ecosystem that we have created. This is our garage facility, 75,000 square foot space, where you could come in, fly your drones, build your drones from the ground up, and I'll show you some examples of that work, right? And of course, also the AI infrastructure. Right? This is our garage facility in Jalahalli on HMT campus. Examples of the work we have done. You are seeing a vertical takeoff and landing drone built from scratch, not assembled from parts, brought from somewhere else. This is almost a 4-meter wingspan, right? Core of this is AI. So physical AI is a very, very important element of what India needs to build. Another example, these are core sensors. Sensors and chips are stuff that India does not make today. And we are building these startups from the ground up, right? Not by putting a call and saying where it's already there. We ask, what does India need really, right? Another example, we talk about humanoid robots, but in building humanoid robots, we realize that core actuators is a key element of what we need. Actuators are 60% of cost of any robotic system, right? And we have created harmonic actuators from the ground up, and now it's being adopted. So I will just quickly go through this. I just want to highlight one startup, Zentik. They are working on scientific and engineering AI. They are just now winners of one of the India AI Mission's foundational model challenge. So they are looking at things like thermal analysis through AI, as opposed to the old way of doing things. So let me quickly shift to the other side, which is our social impact portfolio. Fundamental model remains the same. We start with a need or something very early, ask what does India really need? How many of you remember COVID? Any one of you lost friends or family to COVID? Okay, great. How many of your companies were involved in the COVID response? You either donated or you were involved in some volunteer effort. How many of you were involved in COVID response? Wonderful, right? Okay, so how many of you today are still doing it? Because COVID was a war. COVID was a war. It's like a heart attack. We all got up, and as a nation, we started exercising, right? For a little bit. Now, do we have pandemic preparedness? If let's say, there was one more COVID that were to happen, how would Bangalore be different? Do you think we would be different? I hear all of you shake your heads. Why not? Because we tend to forget. We forgot the war that happened 4 years ago. Meanwhile, climate change is accelerating, which means you'll see 4,000 more zoonotic events where pathogens come over from the animal side to human side within the next 50 years. Which means in your lifetime, or perhaps within the next 5 to 10 years, it's very likely you'll see more COVID-like threats emerge. So that's why we asked, we made this cartoon as a vision in 2021. We said, okay, if a COVID were to happen again in 2030, how is the world different? How is the world different for the commoners? Right? I will go to the extent to say most people in this room are privileged. The reason you remember COVID is that for the first time, health tragedy hit our families and our friends. For the first time, you did not have access to hospital bed when you needed. You did not have access to oxygen when you needed. You did not have access to ICU when you needed. That's the reason you remember it. Whereas in a country where top 1% of the population has 60% of the wealth, and the bottom 50% has only 6% of the wealth, you really need to think, how do you reimagine health systems? So we said, let's say Shanti wakes up with a cough in some remote rural India. She speaks the way she normally does. Remember, this is 2021, before ChatGPT hit, before Bhashini really took off. We said she needs to communicate with AI in a very natural way. And based on the tests and biological data that we captured at the front lines, and the contextual data through a One Health and Climate platform, she gets an AI-driven score, a low urgency score, but 2 notifiable diseases, and it connects her to a doctor immediately. Inherent in this vision are 3 types of AI. Typically, when we say health AI, we think of X-rays, taking an image, listening to cough now perhaps, maybe looking at health data. But remember, during COVID, the thing that really, really helped us a lot, but not enough, turned out, was population scale AI. Predictions of how many ICU beds do you need, understanding where do we need to shut down and where can we open up. So that's all population scale data and AI. Typically, administrators think of that. The second, what we think of health AI typically is the individual level AI, of course. And the wrapper or the base on all of this is really natural language. Because now with Gen AI, we are able to gather insights. We are able to make sense of it. We are able to gather data. We are able to make sense of it and respond in a way that's actually useful, even if you are not, digital literate or digital natives. And this is our portfolio. We work across what we call One Health, dengue and climate, heat waves. For the first time, heat waves are being brought up as a direct cause of death. Indirectly, they actually affect a lot more people. Livestock diseases, because we need to build ways to capture data across ecosystems. And of course, environmental surveillance. Individual data and AI, and natural language. We won several awards, including most recently Google.org AI Accelerator Challenge. There were 3,000 applicants and 20 winners. Let me jump in a little bit to some of these things. So why did we start with dengue? We did that in the shadow of COVID. Dengue is something that affects you every day. When I say you, I'm talking about perhaps mostly low-income populations. But for them, once you get dengue, that might be 1 month loss of income, which is the difference between being just above poverty line or below poverty line, right? So we picked up dengue because, one, it's something that the system grapples with all the time. It's not a special event. And it's endemic, and it's climate sensitive. The result of that is this One Health and Climate platform that now brings data from multiple sources together, not just health data, And it enables multiple researchers. None of these are static models. Dengue patterns, climate patterns, movement patterns, all these change all the time. So you cannot have a static model. So you need a live model that's continuously running. And you need to work with the right stakeholders to do that. So we worked with Government of Karnataka, and it's actually deployed in a pilot mode currently. It's not appearing quite clearly. That's a kind of a cycle. The thing I want to call out is the stuff beyond the AI. The AI stuff is the bright blue that we typically just pay a lot of attention to, right? It's a dark blue, building shared understandings. What does it mean to predict dengue accurately when dengue is underreported by at least 10x? So if you try to build that AI, it will fail. What we realized was Karnataka government really needed to know which are the 20-odd sub-districts that they aren't expecting dengue to show up, that might show up. So just they needed to understand some sort of a risk stratification across their sub-districts, and they needed it 2 to 4 weeks ahead of time. So a perfect kind of prediction that is just like 2 days before was not going to help them. An imperfect prediction is okay as long as it's 2 to 4 weeks ahead of time. So you really need to work with the systems to understand and define your data problem and the AI problem, because that's what leads to actual actions, right? Yeah, this is a featured case study, and we also won a Scotch Award. A key thing to call out in all this is we play often an assistive role or an anchoring kind of role. The AI researchers here are from IISc, Indian Institute of Science, or other research institutions often, right? And we work with the government and nonprofits on the implementation side. It's not about AI, it's about solutions based on AI, right? This is true in industry too. A lot of you are probably grappling with amazing AI results that do not translate well into deployment settings, right? So this is the same thinking you have to bring if we want to reimagine our health systems, right? You may have a software product, but that only has impact along with workflows such and such, right? Because ultimately we are not, I don't think we are uploading vaccines yet down from the internet, are we? Right? Physically, atoms need to move if there's going to be healthcare impact. Moving bits is not enough, right? So you need to really think of the whole systems approach. Another thing, a lot of the AI out there in healthcare is built not on Indian data sets. Right? Even if you say India, does a chest X-ray algorithm built in clean lungs of, let's say, Nagaland, is that going to work in New Delhi? Do we actually know that? How are we going to benchmark and choose between various chest X-ray algorithms? I seem to have lost my slide here. Bit of a glitch. Okay, there. So Midas is an effort where we are bringing together high-quality, purpose-driven data sets. I use the word benchmark with a little bit of trepidation, but essentially you need this kind of high-quality data sets to be able to compare algorithms, right? And within that, there are lots of things. This is the DPI story, right? Model T could not have been built without us having, not us, Mr. Ford, having part names, part specs, supply chains, assembly lines, test tracks, standards, and of course the people. So that's the DPI for AI building. And we need this in healthcare for population scale health. Similarly, for running the solutions too, just before us were Cisco, you're talking about in enterprise and corporate settings. Similar things are required in healthcare. But these being public systems, we need to look at it more from a DPI angle, right? The roads, the field, the feeling, the ongoing monitoring of algorithms, so on. A lot of attention is typically given to the AI model training. We work a lot with the systems on other stuff, the use case definitions, the data requirements and standards, and of course, post-deployment monitoring and updating, right? This is the Midas effort that we are working on along with Indian Council of Medical Research, ICMR. Right? Oral cancer screening, this is an app led by IISc and a consortium of partners. We played a heavy assistive role in this. And we've been able to develop an AI, phone-based AI cancer-based screening app that is currently in the regulatory process. But the speed of doing this is enabled by basically digital shared infrastructure along the lines I just mentioned. Right? Now we are bringing the same thinking to TB, where multiple companies have the algorithms, but we are saying how can we help the states to actually compare algorithms and help them create data sets that enables them to deploy. Finally, the hot topic of the day, obviously Gen AI. This is what really has caused the latest surge in hype around AI. Right? The reason I say hype is because, sorry, this is a PDF, so that's not going to work. The reason I say hype is it's important to remind ourselves that there's a lot of excitement of technology, something or the other, every 5 to 10 years. But if you really look at the outcomes in health are measured by something called DALYs, right? Daily adjusted life years, or QALYs, quality adjusted life years. That happens, those outcomes, turns out, a lot of technology has not actually sufficiently delivered it. Right? We come to conferences such as this, we are excited about AI. But if we are really going to help improve outcomes, we have to think about what does inclusive AI look like. Right? And language is a key. Sorry, I'm going the wrong direction. Language is key to that. We have been leveraging Indic language AI as well as Gen AI to create assistive tools for frontline health workers. India has very few doctors, but India probably, between various cadres of frontline health workers, probably have between 2 to 3 million of them. That's who we have to empower to provide quality health care. And we are doing this with one of India's leading nonprofits called Arman. I want to call out a few things. Right now, this is really deployed across only 3 districts in UP. Right? But it's been a journey for us. I want to look at especially these 3 greens, 97% satisfactory. And this is mixed language, Hindi and English with local dialects. Right? 96% positive user feedback. But most importantly, what has happened is number of escalations have reduced from 40% to 20%. Right? And a lot of this happened before we built AI. We actually worked on other user research. We understood, for example, that if the AI has a male persona, the ASHA workers and ANMs did not interact with it sufficiently. We understood while they wanted to be able to ask in mixed text and speech and mixed language, they wanted their responses, especially when they are with a patient, to come not as voice responses, but as very concise text responses and tell them clearly what they need to do. They did not want whole regurgitation of LLMs about knowledge of the condition. So this requires a very specific approach of understanding your user needs and behaviors in depth and a continuous development process. This is not a process of just developing something and putting it out there. 2 things I want to call out is the actions beyond AI that has impact, right? At least in the real world, in the kind of settings we work on, right? I won't go into this. We have a framework where we ask, what are good models? Everyone wants to apply AI for everything. Where should we apply? Where should we not? Right? So we often ask that question. Often AI is not required. It probably is a more expensive or cumbersome way of doing it, right? So we steer folks away from it. Perhaps the biggest slide is it's iterative. There are no plug-and-play solutions. And here is where our industry partners, philanthropy partners, industry philanthropy, I would say. So please come contribute to making India war-ready during peacetime, be it in building drones or be it building healthcare solutions for population. Right? Thank you. You have my contact information there. Look us up.